Three, two, one. We are live now, sir.
Great.
मिशन पण तयारी बंद करते गाड़ी बात कर हाँ ચાલુ થઈ
उसका कार લાવું છું આપણે કાર લઈને આવ્યો છું સર તો
કાલે
જે રીતે દુબઈ
તો બેનને 11 ને કહો કે કાર લઈને આવ્યા છે તો એમની કાર અમારી કાર છે પૂછી चालू करते हैं क्या क्या हुआ
Yeah, Manoj sir.
Yes,
Yeah, you can start.
with the kind permission of our program directors, good evening, ladies and gentlemen. Welcome to 46th episode of Secrets of Neurology. It's a knowledge feast for all the neurologists. And this time we have an interesting case presentation on quadriparesis in a young man, a rare causation, by Dr. Ramesh Cardiac and Multi-Speciality Hospital, Guntur. All has been the brainchild of our program directors, and a warm welcome to them, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan. And I would also like to welcome Dr. Kumar Velu, Dr. Deepthi, Dr. Lakshmi Bhavna, and the entire team of Dr. Ramesh Cardiac and Multi-Speciality Hospital, Guntur. As we all know, that this is one of the longest running web seminar in the field of neurology. We are about to close the 4th year, and we normally finish it and start on time in another 1.5 hours. Our program director, Dr. Sudhir Sir, Professor and HOD, SMT, NHL, MMC, SBPI, MSR, Ahmedabad. Sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Many awards and accolades and academic contribution to Sir's credit, but just to mention a few, he has been recipient of most prestigious Padam Shri by Government of India for his work in the field of neurology, community and patient service at large. Sir is also recipient of Dr. B.C. Roy Award, and Dr. Sudhir Bhai Shah sir is also recipient of prestigious UNO Award and Global Visionary Award. Dr. Sudhir Shah sir's interest is into stroke, neurodegenerative disease, and epilepsy. Thank you, sir, and a warm welcome to you. Our second program director, Professor Dr. Lakshmi Narasimhan Ranganathan, sir. We all know him very well. Extremely popular in the field of neurology, Director and Professor, Department of Neurology, at prestigious Sri Ramchandra Institute of Higher Education Research Center. Again, another recipient of many awards, accolades, and academic contributions in the field of neurology. Paltussi Advisor from AN, A.B. Baker Award for Global Best Teacher, Best Paper Award from AN, Global Elsevier Atlas Award, and has been making immense contributions in the field of neurology, both in the domestic and in the global neurology field. Thank you both our program directors who has made it so successful that this is the longest running web series in the field of neurology, which is now having audience from India and from various parts of the world. So good evening, good afternoon, and good morning to various parts of the world. May I request our program directors to take it forward from here.
Thank you. Thank you very much, Dr. Manoj Kumar, for your kind introductory words about the program as well as the program directors. Thank you. You have already said a lot of things, so I don't have to add more, except that I have to thank all over again to each and every person who is a part of this program, mainly all those people who have presented their cases in the last 45 episodes. And of course, for today, I have to thank Dr. Kumar Velu sir, Dr. Dipti and Dr. Lakshmi Bhavna for presenting the case of quadriparesis in a young man, a rare condition. That's the 46th webinar of this wonderful series. The series is wonderful because all of you, all the neurologists of India and abroad have taken a lot of interest and given a wonderful feedback. So we, that is myself, Dr. Sudhir Shah and Dr. Lakshmi Narsihan, we are very grateful and our heart is full with gratitude and affection toward all of you for your continued support and encouragement. I am also here to thank Mr. Arun Chadda, Dr. Manoj Kumar, Dr. Shweta and team Celestial is in task for the continuous logistic support and the networking for this program. We will be now completing 47 program in the end of this month, maybe 31st May as we have targeted. And so in the month of June, we are planning to celebrate completion of 4th year in a little larger scale, and we are working on that. So thank you once again to all delegates for your continuous support. Thank you. And with that, may I have the next slide, please? See, the presentation will be done by DNB resident Dr. P. Lakshmi Bhavna, who will discuss will present the case. Dr. K. Dipti is a consultant from the Department of Neurology. She will she is from the Dr. Ramesh Cardiac and Multispecialty Hospital, Guntur, Andhra Pradesh. She is a MBBS, MD General Medicine from Guntur Medical College and DNB from same Ramesh Cardiac and Multispecialty Hospital. And she has published a case of rare neuropathy poem syndrome. Next slide, please. And Dr. S. Kumar Velu, one of the most brilliant stars of South, is Professor, Senior Consultant. Hello. There's some background noise. Dr. Kumar Velu is a Professor, Senior Consultant and Chief of Neurosciences, Esther Ramesh Hospitals, Guntur. His area of specialization is acute stroke, CVT. He has publications in American Journal of Cardiovascular Drugs in 2018 on efficacy and safety of intravenous tenecteplase bolus in acute ischemic stroke. That was results of 2 open-label multicenter trial. Second was a very important publication of Journal of Neurological Sciences, clinical profile and outcome of non-COVID strokes during pandemic and the pre-pandemic period COVID stroke study group. And in Neurology India, he published in Jan 22, acute hemorrhagic leukoencephalocele with COVID-19 and dengue infection. He has been conferred upon with several awards, including M.G. Kinney Memorial Prize, A.N. Menon Gold Medal, University. He was a university topper in anatomy, and Lieutenant Colonel K.K. Gupta Gold Medal was Commendation 2007. So he's also a fellow of Indian Academy of Neurology, and so he's a very thorough gentleman with a lot of academic and other achievements. So he will be giving his expert comments and he will conclude the thing. So after the case presentation by Dr. Bhavna, Dr. Dipti ma'am will give discussion comments and sir will conclude and give summary. With that, I hand over the mic to Dr. Kumar Velu, but before that, as always, I am very thankful to my colleague, Dr. Lakshmi Ranganathan, Lakshmi Narasimhan Ranganathan, who is the backbone of this webinar series. And it is his tireless efforts that has made this series always running uninterrupted. And many times we were stuck who will be presenting the next, and somehow he will connect with some important institution and we will have no break. So this is a breakless, wonderful, most awaited, most sought after, most, I would say, knowledgeful webinar series, and thanks to all of you for having all these accolades for this series. Thank you so much. Dr. Kumar Velu, sir, please take over.
So before that, I would like to thank Professor Kumar Velu, sir. We are very proud of you that you have served the Indian Army for so many long years, acquired the very highest post in the Army, very thorough gentleman of his kind, and more than that, the academic, the neurology academic aspects of the Army was for Dr. Gothi, Dr. Narayanan, Dr. Kumar Velu sir. They always had the Indian the Army flag flying high in terms of academics. I'm very thankful to you for accepting our.
Yeah, so there is an additional salute because there is a flavor of Army. So we really salute you, sir,
Over to you,
for
sir.
all your
Sir, can you hear me, sir?
service. Yeah.
Can you hear me, sir?
Yes, we can.
I can hear you.
Yes, we
I
are
can-
here. We are able to hear you, Lakshmi. We are able to hear you, Dr. Lakshmi. You want to say something more? Okay. I think Dr. Lakshmi is boarded the flight, so probably connectivity is a little low. Anyway, so let us have
can you-
now
can you-
Dr. Kumar Velu.
Sorry, sir. Can you hear me, sir?
Yes,
Sir, I just
very
wanted
well.
to thank Professor
Good.
Kumar Velu, who was
Thank you.
served the Indian
Thank you.
Army for so many years, held highest post, and held the Indian national flag high, and as a neurologist in the field of academic neurology in the Army, Sir Dr. Kumar Velu has a unique place. He has, along with Dr. Gothi and Dr. Nande, Indian Army flag. They in the academic neurology field, they kept it high. Thank you so much for your kindness, sir, for accepting our invitation. Over to you, sir.
Thank you, Lakshmi. Thank you, Lakshmi, and thanks a lot for the nice. Thank you, Professor Shah, and thank you, Manoj and the team. With this, we'll start the presentation by our resident, Dr. Bhavna. She'll give a case. This is a rather interesting case for us. It kept us perplexed for quite some time before we could reach a conclusion. Right? Over to Dr. Bhavna.
Yes. Good evening, sir. Today I'm going to present a case of quadriparesis in a young man with a rare cause. Good evening. Today I'm going to present a case of quadriparesis in a young man with a rare cause. So a 28-year-old who is a resident of Tenali, working as a receptionist in a hospital, presented with weakness of all four limbs and a tingling sensation of all four limbs for 1.5 month duration. History of present illness. Patient was unemployed for the past 1.5 year before the presentation to our hospital. He was staying at home. He used to play mobile games most of the time, and he was confined to the bed, and he gets up only to attend his nature calls and to eat food. He gradually noticed weakness of both lower limbs for the past 1.5 month in the form of difficulty in getting up from sitting position after eating food and difficulty in getting up from the chair. He attributed these complaints to improper food intake and ignored it. Later, he joined as a receptionist in a hospital 1 month prior, where he has to stand for most of the time. During that time, he found difficulty in standing and he used to shift his weight on alternate legs, and he sustained repeated falls due to sudden giveaway sensation at both knees. These falls are not associated with any loss of consciousness. He had difficulty in climbing upstairs, and he felt difficulty in insinuating toes into the footwear for the past 20 days, and he used to wear with the support of his hands. For the past 15 days, weakness was noticed in both upper limbs simultaneously in the form of difficulty in lifting the mug filled with water while bathing and difficulty in taking objects from high shelf. Later, within 1 week, he noticed worsening weakness in both the hands in the form of difficulty in breaking chapatis, opening a bottle cap, and difficulty in gripping and writing. This weakness was associated with looseness of limbs. There was history of thinning of all muscles with overall weight loss of 10 to 12 kg in 1 year duration. It was not associated with abnormal twitching. There was no history of difficulty in raising head off the pillow, no history of difficulty in turning head sideways on the bed, and there was no history of diurnal variation of the weakness. He had history of tingling paresthesias of both lower limbs for 1.5 months. Initially, it was started in both feet and progressed circumferentially up to the knees in both lower limbs within a month. For the past 15 days, he also noticed paresthesias in both hands extending circumferentially up to the wrist joint. He also noticed decreased pain perception in these areas, but he was able to feel hot and cold sensation. There was no history of cotton wool sensation while walking, girdle sensation, or Lermit's phenomenon. There was no history of any involuntary movements. There was no history suggestive of cranial nerve involvement. There was no history of abnormal sweating, postural giddiness, bloating, skin changes, or bowel and bladder disturbances. There was no history of swaying while walking or tremulousness of hand while holding objects or slurring of speech. There was no history of memory disturbances or behavioral abnormalities. There was no history of trauma to spine and head or pain in the neck or low backache. There was no history of fever, diarrheal illness, or upper respiratory tract illness prior to the onset of symptoms. There was no history of any insect bite or recent vaccination. He had a history of loss of appetite and weight loss of around 12 to 14 kgs over a period of 1 year. There was no history of skin rash, joint pains, or oral ulcers. There was no history of exposure to drugs. Past history, he had no similar complaints in the past, and there was no history of diabetes mellitus, hypertension, bronchial asthma, epilepsy, or hypothyroidism. Personal history, he consumes mixed diet, his appetite was decreased, and he had delayed onset of sleep. His bowel and bladder habits were normal, he was non-alcoholic, and he used to smoke, but he had quit smoking 4 months prior to the onset of symptoms. There was no history of high-risk behavior. There were no history of similar complaints in other family members. He was not on any medication. His functional status at the time of arrival to the hospital was he was unable to perform his activities of daily living independently, and he requires 2-person support to stand and walk. So to summarize my history, a 28-year-old male who is an ex-smoker presented with subacute onset, gradually progressive weakness of both upper and lower limbs, associated with tingling paresthesias and decreased pain perception of all 4 limbs in the stocking and glove distribution, with sleep disturbances and loss of appetite and weight, sparing cranial nerve, autonomic, cerebellar, and extrapyramidal systems, with no features suggestive of raised intracranial pressure or cognitive disturbances. So functional deficit of the patient was subacute symmetric progressive sensory motor quadriparesis of lower motor neuron type. Because the weakness is of lower motor neuron type and involving both proximal and distal muscles, and the sensory loss of glove and stocking pattern, I would consider anatomical localization to be peripheral now. And based on this, my differential diagnosis would be most likely causes are subacute inflammatory demyelinating polyradiculoneuropathy and nutritional polyneuropathy, and infectious causes like HIV, hepatitis B, hepatitis C, or vasculitis. And although uncommon at this age, I would also like to consider paraproteinemia and paraneoplastic causes. His general condition on examination, he is conscious and coherent, moderately built and ill-nourished, with a BMI of 18.75 kg per meter square. He has no pallor, icterus, cyanosis, or clubbing, or pedal-edema and lymphadenopathy. Examination of skin, hair, and nails was normal. There were no skeletal deformities. There was no thyromegaly, and there was no peripheral nerve thickening. Vitals were normal. There was no postural fall of blood pressure. Single breath count was 19. CNS examination, he is conscious, coherent, and cooperative. He is a right-handed individual. His speech was normal. Mini mental state examination and lobar functions were normal. Cranial nerve examination was normal. And motor system examination, he was sitting on the edge of a bed with both legs dangling down with bilateral foot drop. Generalized wasting was present. Tone was decreased in both upper and lower limbs. Power, neck flexion and extension is normal. Tongue power was normal. There's an image showing bilateral foot drop. And these are the images showing wasting of intrinsic muscles of hand. Power in the upper limb, shoulder flexion was 3/5 bilaterally, extension was 2/5, and abduction and adduction was 3/5 bilaterally. Internal rotation and external rotation were weak. Elbow flexion is 3/5 bilaterally, extension is 2/5 bilaterally. Forearm pronation and supination was 3/5 bilaterally. Wrist flexion and extension is 3/5 bilaterally. Hand grip is decreased to less than 50% in both hands, and intrinsic muscles of hand are weak. In the lower limbs, thigh flexion is 3/5 on both sides, extension is 2/5, abduction is 3/5 on both sides, and adduction is 2/5. Internal rotation and external rotation are also weak. Knee flexion is 2/5 on both sides, extension is 0/5. Ankle dorsiflexion and plantar flexion are 2/5, inversion, reversion are 2/5, and extensor hallucis longus is weaker on both the sides, and intrinsic muscles of foot are also weak. Reflexes, superficial reflexes, corneal, conjunctival, abdominal reflexes are present, and plantar reflex is flexor bilaterally. Jaw jerk, biceps, triceps, supinator, knee and ankle reflexes are absent bilaterally. Sensory examination, pain and fine touch are decreased in both upper and lower limbs in the stocking and glove distribution. Vibration sense was decreased at both medial and lateral malleoli, and joint position sense was lost in both the lower limbs, and Romberg sign could not be elicited. Cerebellar examination, cerebellar signs were negative, and gait couldn't be tested. Spine and cranium were normal, and there were no signs of meningeal irritation. Other system examination, respiratory system, chest expansion was 5 centimeters. There were normal vesicular breath sounds with no added sounds. Cardiovascular system is was normal, and there was no organomegaly. To summarize my examination, a 28-year-old male with presented with subacute onset progressive symmetric areflexic quadriparesis, distal more than proximal weakness with generalized wasting and bilateral foot drop with stocking and glove pattern of sensory disturbances involving both small and large fiber neurons with loss of appetite and weight, sparing cranial nerves, autonomic, cerebellar, and extrapyramidal systems with no signs of raised ICP. My provisional diagnosis remained same after the examination. My differential diagnosis also remained the same. So with this in mind, we went ahead with the investigations. Blood investigation showed normal hemoglobin and normal blood cell counts. Other blood parameters were also normal. ESR was 20, random blood sugar was normal, blood urea and creatinine were normal.
Before the investigation, do you want any discussion at this point? No, you want the investigation after the investigations, but any discussions for that at this point, or you want to continue or finish the investigation and have the discussion? As per whichever is comfortable for you. Hello? If you are comfortable after the investigations discussion, you continue. Thank you.
Yes. So serum electrolytes and calcium were normal. Viral markers were negative. Liver function tests were normal. Thyroid function tests were normal. Vitamin B12 levels were normal. Vitamin D was severely low. And serum CPK and ANA, serum CPK was normal and ANA profile was negative. ECG showed normal sinus rhythm and ultrasound abdomen showed no organomegaly. So these are the nerve conduction studies. Motor nerve conduction studies show markedly reduced nerve conduction.
Bhavna, sorry to interrupt you. There was a question from Dr. Lakshmi Narasimhan.
Yes, sir.
There was a question from Dr. Lakshmi Narasimhan. Lakshmi, can you repeat this comment? Hello?
Do you want a clinical discussion, or do you want a clinical discussion at this point or at the end of the investigation, sir?
Yeah. We can have a clinical discussion and then come with investigations later.
Yeah. That's what I thought. That's what I asked, sir.
Yeah.
That's what I asked.
Definitely. Yeah. Bhavna, did you hear what Dr. Lakshmi said?
Yes, sir. Yes, sir.
Yeah. We'll come with the investigations once we make a clinical discussion on this thing and detail. Is anybody from the audience would like to comment before we give it? Get back to the slide, no? Your summary slide. Yeah. Somebody has mentioned DADS. What does it mean?
Distal acquired demyelinating system motor neuropathy.
I saw a word written there, DADS. Paraprotein related. Yeah. Bhavna, would you like to answer the question? One audience person is asking, is it paraprotein related? Can show your, this gave the summary, gave the localization, and then what about the discussion at this stage? He is
Yes, sir.
asking, is it
Also
paraprotein related?
kept that under the differential diagnosis, sir. You also considered paraprotein.
You
Also.
got to answer him, no? He is asking, is it paraprotein related?
It could be, sir. That's why we also included that under the differentials.
Bhattacharya, it is mentioned in the differential diagnosis also there. If you can see there. The first possibly consists subacute inflammatory demyelinating polyradicular neuropathy. Nutritional polyneuropathy comes second. Infectious causes in South India has to be kept in mind. Vasculitic polyneuropathy was the third. Paraproteinemia with polyneuropathy was considered below that. And last, paraneoplasm, because he's a young guy with no obvious malignancy either in the family or in himself, that was kept at the end. Right? Any other questions? Any other comments or questions from the audience? Lakshmi, anything else do we discuss at this stage?
No, sir. No, I think everything about what you have discussed, most of the differentials. Only thing, the loss of appetite and the loss of weight requires loss of appetite and loss of weight,
Yes.
and needs some explanation. Is it the such a significant loss of weight and loss of appetite in a subacute? So Butch nutritional also very much
that's
under.
why we have kept number 2 nutritional. That's the reason
that's
we
what
kept
that keeps the
number 2.
nutrition high on the list. You have done that, sir. So I think we should go ahead, sir. Thank you.
Yeah. Anything else? Deepthi would like to add
Hello.
anything there.
Yeah, Dr. Kumarvelu, I was wondering,
Yes.
in between the line was disconnected from my end, but I just missed whether we have discussed about any skin markers or hepatosplenomegaly or ophthalmic findings. Just is there any
Come again,
clues
sir?
on this?
Any?
Am I audible? Because I'm in transit, so maybe. Is there any evidence of hepatosplenomegaly, skin changes, or
Yeah.
papilledema, or some other markers of endocrinopathy or any other, or for that purpose, cardiomegaly or any other clues to the diagnosis on clinical grounds?
Yeah. Bhavna and Deepthi, would you like to answer sir's question? Sir's comment?
No, sir, there was no organomegaly, sir, and no
Hmm.
gynecomastia, no thyroid swelling. There were no skin changes also, sir. Skin or hair changes.
Or okay, very good.
Right. Toxins. Somebody has given a question. Abhilash from the audience is asking toxins and put a query. Abhilash, what do you have in mind? If he can be unmuted, we can hear him what he has in mind. And one person from the audience needs to mention that history of being a smoker is also to be considered. Yes, we did consider. We'll
Yes,
come
sir.
back. We'll come to you with further details once the basic investigations are completed. Right? I think we'll go ahead, sir. If you permit, we'll go ahead with the investigations.
Yes, sir. Yes, sir. Yes, sir.
So motor nerve conduction studies showed markedly reduced conduction velocities and mild prolongation of distal latencies in right ulnar and left median nerves. And in the lower limbs also, conduction velocities were decreased with decreased amplitudes in peroneal nerve. And sensory nerve conduction studies showed decreased amplitudes in sural nerves bilaterally. And F-wave latencies were prolonged in left peroneal and left ulnar nerves, suggesting severe predominantly demyelinating sensory motor polyneuropathy with some axonal changes. CSF analysis showed no albinocytological dissociation. Here on the second day of admission, patient revealed that he has a history of substance abuse in the form of glue sniffing with Fevicol from 2017. He used to initially sniff in small amounts, that he used to complete 1 liter bottle in 20 days. He gradually increased the dose to get the desired effect. That is, he used to finish 1 liter bottle every 1 week. He abused it for a period of 3 years, and he was then in rehabilitation center for 10 days and completely abstained from that habit for 1.5 years. And from July 2022, he restarted sniffing again. But this time, he used to sniff in increased amount. He used to finish 1 liter bottle every 3 days. And he used to do it almost throughout the day without any food intake. And he used to sleep at 4 o'clock in the morning. He used to get withdrawal symptoms and no sleep during abstinence. His last exposure was 3 months prior to the onset of illness. So this is the substance he used, which is a synthetic rubber adhesive containing aromatic hydrocarbons like N-hexane, toluene, and aliphatic ketones like methyl ethyl ketone. So he was empirically started on in methylprednisolone 1 gram IV OD for 5 days. MRI brain was done to rule out any white matter changes secondary to toluene, but it was normal. For diagnostic purposes, a sural nerve biopsy was done, and histopathological examination showed acute axonal breakdown changes and non-uniform loss of myelinated fibers with occasional regenerating clusters, implying subacute to chronic asymmetric axonal and demyelinating neuropathy, and with suggesting a toxic etiology. This is the transaction of nerve showing nerve fascicles in hematoxylin and HNE stain. And this is the Kulczycki-Pal stain for myelin, showing axonal sprouts and regenerating clusters. And this is the same showing axonopathy. He was discharged in a hemodynamically stable condition with maintenance dose of steroids and other nutritional supplements with complete abstinence from the glue sniffing. This was the initial video at the time of presentation. He required 2% support to stand and walk. And this video was 1 year after complete abstinence from the substance. He regained almost most of his power, and he only has some mild sensory complaints now. He also started working again. So based on this, our final diagnosis, it was considered to be due to inhalation of vaporized elements of the adhesive agent containing mainly N-hexane. N-hexane is considered to be chiefly responsible for polyneuropathy, although toluene also could have some influence on the illness. So glue sniffing, it has 3 methods: huffing, puffing, and bagging. Our patient used the method of bagging. Over to Deepti ma'am for discussion.
Good evening, sir. Myself, Dr. Deepti. So, our patient, 28 years old male with the symmetric length-dependent sensory motor polyneuropathy. At the time of our presentation, we wanted to rule out first GB syndrome. So we proceeded with the nerve conduction studies, and later we admitted him for CSF analysis. So, as to decide on whether to give IVIG or to proceed with plasmapheresis. Later, we came to know that his habit of sniffing glue for the past almost 5 years, and he used to take large quantities for the past 3 months prior to the onset of illness. Usually, after knowing this history, we reviewed the literature. Literature also showed many old reports of glue sniffing neuropathy, and first case was reported in 1974 from Japan. Until then, also, so far very little much cases reported secondary neuropathy secondary to glue sniffing, accounting for about 17 to 20 cases were reported from various countries. Chronic low dose exposure of chronic low dose exposure to N-hexane is known from industrial areas. And glue sniffing neuropathy secondary to substance abuse is less well documented. And acute worsening of this neuropathy will present like GB syndrome. In cases of GB syndrome with diagnostic uncertainty, one should keep the possibility of this toxic neuropathy secondary to N-hexane. And these solvents like these glues, paints and thinners they are easily accessible and inexpensive, and making them a most liable objects for abuse. And the type of habit is most prevalent in males and teenage groups, and there were reports of group abuse of these substances also. And as Bhavna told, our patient adopted the method of bagging. He used to put some glue in the carry bag, and he used to breathe in and out of this carry bag, which will create fumes, which gives the pleasurable effect by stimulation of this dopaminergic system. And because of this repeated exposure to these lipophilic substances will result in progressive demyelination and axonal loss. And as all of we know, these toxic neuropathies usually causes axonal neuropathy, but N-hexane is specifically known to cause predominantly demyelinating neuropathy. And there is no specific test to confirm its causality. So we opted for nerve biopsy, even though nerve biopsy is usually preferred in vasculitic and other metabolic neuropathies, but N-hexane neuropathy is usually diagnosed with the specific biopsy finding changes like axonopathy secondary to neurofilament accumulation and demyelination. And there is no specific treatment, even though we have started him on injection methylprednisolone while awaiting the results for this ANA profile, connective tissue profile, and sural nerve biopsy. We empirically started him on injection methylprednisolone, but he had no improvement with the pulse dose and maintenance dose of these steroids. And abstinence from the substance and rehabilitation is the main modality of treatment. Usually these toxic neuropathies, usually they have a good prognosis, and costing effect, that is intensification of the weakness few weeks prior to the improvement is generally observed in some cases. As in our case, for the first 6 months in follow-up, he reported no improvement, just mild to no improvement he had. Later, after 1 month, he had regained almost his power, and he rejoined in his job. Some concepts generally hold good for toxic neuropathies these are generally dose dependent, that our patient has increased amount of with this substance abuse 3 months prior to the onset, and there is a temporal relationship between the substance abuse and onset of the symptoms. That is 3 months prior he had excessive intake of this substance, and they're usually generally reversible given an adequate time with the substance with abstinence from the substance abuse and physical and occupational therapy. So one should obtain a good addiction history in a case of suspected toxic neuropathy cases. So, and early diagnosis is important to promote the patient from abstinent from that substance, and to promote early recovery. Kumarvel sir, your comments please, sir.
Deepti, there are 2 questions in the mail chat box. What I'm this thing is that
Actually, there is no role for steroids in toxic neuropathy. While awaiting the results for connective tissue profile as well as sural nerve biopsy, we empirically started methylprednisolone. Actually, there is no role for steroids in toxic neuropathy. Mainly abstinence and rehabilitation is the main modality of treatment.
Right. Right. So what's important? That answers the question. And there was a question, why is such a long latency between the glue sniffing and the onset of the illness?
As I told, there is a temporal relationship between the onset of symptoms and substance abuse. As we told, our patient had increased amount, that is, he completing 1 liter within 3 days, just 3 months prior to the onset of symptoms, which explains the onset of symptoms in our patient. That is the temporal relationship.
Yeah, fine. The slide presentation can be stopped. We can ask the audience whether they have anything else in mind. And otherwise, the aim of bringing this case to this August group is to understand that what is common need not always be the cause. But yes, in clinical neurology, we always teach that common things are common and it should be considered. Rarely one can be beset with such a situation. Just accidentally we got the information and we could reach the diagnosis and back to normal with due psychiatric counseling as well. And this is the most uncommon thing that we have come across. We'll be reporting it shortly. There was some delay in report. We'll report it shortly. Any comments from Professor Shah?
I think very intriguing and very interesting case, and it looks like that from the history of inhalation of this agent and the temporal relation and the way from abstinence the patient is stable, I think the diagnosis is more or less justified, and I'm sure you have carefully explored all of the causes. So this is really a great lesson, and again, careful history and keeping all toxic causes of neuropathy in mind should be one of the important things. But as you mentioned, there is no other therapy. It is only abstinence and rehabilitations. Great. Wonderful case, really. We are very, very enlightened with this case. I have heard for the first time, I mean, somebody has presented this case. There's written in books, but I don't think we see them that often.
Sir, thank you for an excellent case, Professor Kumarvel. Sir,
Yes,
the first case of glue sniffers neuropathy, I came across because I practice in a school zone. Sir, the first time, one boy came with this similar picture, and I asked him. Then he said that where did you get they sniff the Fevisticks, sir. The Fevisticks and the Feviquick, those things they buy. And on inquiry, the shops near the schools sell almost 100 sticks of these adhesives per day. Then I was wondering, I just explored that, and to my surprise, that there are glue sniffers club there in engineering colleges. It is not. It's a good thing that you brought this as an eye opener for this forum. It is not very uncommon, and it is now among the youngsters. This has become a rampant thing, sir. They also get some euphoria. You can see that these people put the Feviquick in a cell phone bag and then start sniffing the bag, sir. This you can see near the school side. When you notice, very carefully watch a couple of guys stay away from the school crowd and then do this. And I was shocked, sir. This is toxic neuropathies is one entity which the younger generation of neurology should not forget, sir. Thank you for giving one excellent case. Thank you so much, sir.
Thank you, sir. This is the reason why we brought it out, sir. This guy was carrying on with this thing repeatedly, doing this. he went to Hyderabad for doing some studies and some working. He was working in an electrician department. Then he got into this habit, and then he has to leave the job, came back. Eventually, the family brought us. We are also perplexed initially what we are treating, what we are dealing. So that's the reason we thought that we'll bring it to the audience so that most of some more of our colleagues will be
Yes,
wiser
awareness.
than what we were in at
The
that time.
awareness has to be there, sir, because we normally don't, get into this. Now, I
Yeah.
think as a routine, after that, I started asking for sniffing also, sir, regularly.
Yeah.
Regularly, I've
Yes.
started in any neuropathy. I've started apart from the Siddha medicines, native intake, and all those rarer things, and most of the few of the gyms which give rise to this, the so-called bodybuilding molecules. All these things can also produce toxic neuropathies. So I want the younger generation to remember this. This is a very interesting, very important part in the management of peripheral neuropathy, sir. Thank you.
So, so Lakshmi, which other type of toxic neuropathy in the youngsters you have seen, as you're mentioning about sniffing, and even Dr. Kumarvelu can
Sir,
answer.
there's one
because-
more thing, what is called a candy trip, sir, which is very popular among the youngsters. Candy trip is a mixture of the dexamphetamine with marijuana. What they do is they take the dexamphetamine, and once they reach the psychedelic delusion stage, they apply marijuana topically near the ear using the kerchief. And topical, this is called a candy trip. This kind of candy trips, it's very common among the youngsters. In Chennai, at least, there are a lot of guys who take this candy trip, both boys and females. And it produces a psychedelic delusion where the next morning you feel all the past things are deleted, sir. You feel very fresh and you completely forget everything, sir. This is another thing which the boys want to remember. Thank you.
On a lighter note, it seems that the South Indian boys are fond of lot of new experiments. In Gujarat, we don't see this kind of neuropathies, toxic difference in. Maybe we'll be more careful now in eliciting this type of compound histories. At least I haven't seen either of these two. We have been seeing with some other drugs, but not these two which you have mentioned. Hello. Dr. Kumarvelu, are you speaking?
Yeah.
Your bandwidth
Am I
is
audible, sir?
low.
Am I audible?
Yes, now you are.
Yes, sir.
Yeah.
Yes, sir. You're audible, sir.
As far this thing is concerned, sir, this is a case which made us wiser. And as Dr. Lakshmi was alluding to, we started looking into these toxic entities also whenever there is some atypical presentation. That's where we get into it. Like looking like AIDP, maybe the period was not fitting in, or the sensory symptoms are a bit out of proportion, or the sensory involvement was seen on electrophysiology, and CSF being normal. This keeps us open, and then we get back into the history and the period from this boy where he came from. There is a significant belt where these things keep happening. We came to know later. So that's why we became wiser and start discussing things.
Thank you, sir. If there is no other questions, I thank the entire team from Guntur. Excellent case, making us wiser in this presentation. And we have almost addressed all the questions in the chat box also. So we'll probably meet on the 31st of May, the usual last Friday. This time it was postponed due to unforeseen circumstances. Otherwise, we always meet on the last Friday, 31st May of this month. We meet for the 47th episode. I hand it over to the organizers.
Thank you.
Yeah.
Thank you very
Thanks,
much, sir.
everyone.
So today it's really a great day. We are completing our 46th session of Secret of Neurology. On behalf of Intas Pharmaceutical, I, Arun Chadha, extend the heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 46 months. I would like to thank our Honorable Course Director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very, very helpful to all the DM and DNB students. We extend our sincere gratitude to Dr. P. Lakshmi Bhavna, youngest neurologist, for their insightful case presentation. And we would like to express our appreciation to Dr. Dipti ma'am for their meticulous evaluation of the symptom and investigation. And our special thanks to Professor Dr. Kumarvelu sir, and who is the HOD, Department of Neurology, Dr. Ramesh Kardik and Multi-Specialty Hospital, Guntur, for graciously sharing their valuable experience with this case and providing the crucial learning points and proceeding of this unique presentation. Sir has given all the summary and conclusion of this case. Thank you very much, sir. Once again, we are very thankful to you for your gracious presence, and it's being a pleasure being with all of you today in this 46th session of Secret of Neurology. Thank you for your presence, and we will meet again on 31st May with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you very much. Thank you, sir.
Thanks,
Thank you
Manoj.
very
Thanks,
much.
Lakshmi. Thanks, Dipti.
Thank you.
Bye.
Thank you very much.
Very
sir.
much.
Thank you.
Thank you.
Thank you,
very
sir.
much.
Thank you.
Thank you so
sir.
much.
Thank you, sir.
Dr.
Thanks. Bye.
Lakshmi, you stay back, please, for a minute. I'll talk to you. Dr. Lakshmi?
Bye.
Yes, sir.
Sir has already left, sir.
All right. Great.
Yeah.
Bye. So we can talk among yourselves.
Yeah.
Once,
That's what I want to say.
panelists, yeah,
Yes.
Yeah, we can discuss, sir.
yeah.
Vineet,
Once the
can
panelists
you please
leave,
stop
we can
live?
talk.